Good evening. I will be presenting a novel approach of triple pass and double augmentation of NAP procedure in double elevator palsy. Double elevator palsy, precisely known as MED, is defined as limitation of elevation of affected eye in both abduction and adduction, with normal duction in all other cases, and often there is a mild residual hypertropia even after NAP and IR recession. So augmented NAP procedure utilizes NAP procedure combined with posterior fixation foster suture or sutures on the horizontal recti to increase its effect. So to enhance the effect of NAP, we did double augmentation by combination of intermuscular augmentation along with a scleral pass, which creates another augmentation and ensures vector created by this transposition are more effective along superior rectus vector forces and postulated shift of muscle pulleys. So the aim of study was to report and describe the effect of double augmentation of NAP procedure in double elevator palsy in series of 5 patients, and whenever angle is more than 35 prism diopter of hypertropia, augmented NAP procedures are usually advocated. Horizontal rectus transposition, as we know, is always more powerful than vertical rectus, and studies have been reported where intermuscular augmentation and foster suture augmentation not only improve the abduction limitation but also enhances the binocular field in sixth nerve palsy and Duane retraction syndrome. So the similar concept was used in these studies. All in this series, all the cases had large hypertrophy of more than 40 prism diopter and with limitation of elevation in adduction and abduction. And in this, lateral rectus was transposed near the superior rectus, and after transposing at 8 mm, 1/3 of the lateral rectus fibers were taken with the help of 5-0 non-absorbable ethibond suture and then passed at the sclera 13 millimeter from the limbus, and then again 1/3 fibers of the superior rectus were taken, incorporating 1/3 of the fibers, and thus the triple pass along with both the muscle augmentation and scleral pass. Similarly, in the medial side, medial rectus was also transposed, but it was transposed after resection of 3.5 to 4 mm, and 1/3 medial rectus fibers were taken, a scleral pass at 13 millimeter, and again 1/3 fibers of superior rectus were taken. Now, in all the cases, FDT was done to ensure no inferior restriction. So these are the 9 case photographs of case 1 and 2, in which we can see in first case there is right large hypertropia, and post-op there was nice improvement in the elevation of the hypertropic eye, and in second image there is improvement in not only in hypertropia of the left eye but also improvement in limitation in adduction and abduction. Third patient was a pediatric patient, and in this patient also there was improvement in adduction and abduction limitation after double augmentation. Patient 4 and 5 didn't consent for their photograph sharing. So coming to result, all the 5 cases were male, age ranging from 8 to 28 years, with left eye involvement in 3 cases. Fifth case has additional inverse Marcus gun jaw winking. All cases had 45 to 50 prism diopter, and there was residual of 5 to 10 in 4 cases. Only in 1 case had 15 prism residual hypertropia, and in all cases maintained this position at 3 months also. So this is the figure showing where medial rectus resection was done in all cases with 3.5 mm MR marked, and this figure shows both the lateral rectus and medial rectus transposed near the superior rectus with augmentation done at 8 mm. So limitation of our study is that it is a non-comparative study. It is only a case series. A prospective study comparing traditional NAP versus this double augmented NAP could give us more definitive result. So there are several studies in which authors have compared augmented NAP procedure with superior posterior fixation suture, but not in combination with this. Only one study by Acker et al. They did this augmentation NAP procedure along with intermuscular augmentation, and in our series we have additional resection of the medial rectus muscle. So to conclude, this procedure of double augmentation with intermuscular augmentation with scleral suture helps in decreasing the large angle hypertrophy and improvement in elevation in abduction and adduction. So thank you for patient hearing.
So I presume that FDT was negative in all the patients.
Yeah.
So you did only 2 muscles, medial rectus and
lateral rectus. Yeah.
So I think when you do such a strong and concomitant, because I would call it as an concomitant procedure,
Yeah.
It is not very important to see how much improvement in elevation it has made. In fact, there are multiple studies which report that after a few years, and I have seen in my own patients also that after a few years, the eye actually starts drifting even more upwards. So
Yeah,
I would
so
be more curious to know.
the long-term results can be variable because
No, no,
it is
I would be more curious to not only know the long-term results, but because you have already presented your results in 5 patients, so we have to discuss right now this only. So I would be more curious to know what was the point in down gaze and how much binocular field of vision actually improved. Because if we lose out on the down gaze, and these patients are very notorious in down gaze because the moment you pull them up a lot, they actually go blank in down gaze. They lose their, whatever useful binocular vision they had in
all
down
of the
gaze.
patient had nil BSV. Like
Nil?
all, none of the patient had
I was
BSV
talking
present.
about the movement in the
Yeah,
inferior gaze.
so inferior movement it doesn't.
But
It
in the
was not.
photograph, I could see the inferior gaze was affected. There was no effect in the inferior gaze.
No, we have not checked the inferior field as such inferior field, but there was no you are saying in all the patient the elevation improved, but there
The
was
depression did not get
only in
restricted.
one patient. No, depression didn't get restricted.
Oh, that's amazing. That's very good.
The monocular elevation deficiency is primarily
Yeah, so it is always include. That's why it is included in congenital cranial dyssynervation syndrome.
is it a motility disorder or is it strabismus? Strabismus meaning is there a misalignment in primary gaze?
Yeah.
There may not be. So in such a situation where there is no squint but it's primarily a motility disorder, by operating on the muscle, what are you gaining? Nothing. You are worsening the primary situation in primary gaze.
Angle, large angle. It is 45 to 50 prism diopter and along with FDT negative where we cannot do inferior rectus recession. Large hypertrophy. Not the-
So what were the challenges of doing resection along with the
Triple pass.
Yeah, yeah. So yeah, that's why in pediatric case, like we were very worrisome, like doing 3.5 mm dissection should not create the overcorrection. But as all the cases had needle stereopsis and even one case was amblyopic, so we don't know, like if in patient who are having BSV, they can have down gaze diplopia also.